Hello everyone, welcome back to Pharmacology. Pharmacology is the resource I wish I had as a student and new practitioner. Head over to pharmacology.com for complete and detailed study units. In today's video, we will be reviewing sinusitis. Let's begin with an overview of the respiratory system. The respiratory system consists of the sinuses, the pharynx or throat, the larynx or voice box, the lungs, the trachea or windpipe, and the nasal cavity. Each of these parts have the potential for infection. We can categorize these organs into two groups: the lower respiratory tract, which would include the trachea and the lungs, and the upper respiratory tract, which includes everything else above the trachea. In this study unit, we will be focusing on the sinuses. A sinus infection is known as sinusitis or rhinosinusitis. The sinuses are air-filled cavities that are located on either side of the nose and above the eyebrows. They are lined with cells that produce mucus. This mucus drains from the sinus cavities and down through the nostrils via very narrow passages. This drainage helps to clear the nose of bacteria and allergens. So how does infection occur? Sinusitis can be caused by either bacteria or viruses. These organisms cause inflammation in the lining of the sinuses and the narrow passages, which prevents mucus from draining out of the nose. As the mucus accumulates in the sinuses, infection can occur. Mucus can accumulate in one of three ways. The narrow passages become inflamed and blocked off, leading to accumulation, or mucus can be excessively produced and not cleared quickly enough. Anatomical abnormalities like a deviated septum can hinder drainage. Seasonal allergies, nasal polyps, a deviated septum, smoking, exposure to secondhand smoke, and a weakened immune system are some conditions that can increase your risk for developing sinusitis. Signs and symptoms can include a runny nose from excessive mucus, a stuffy nose from the accumulation of mucus, facial pain or pressure, postnasal drip, which is where mucus drips down the back of the throat, and a sore throat, which occurs from irritation from the postnasal drip. The organisms most responsible for sinusitis infections are Streptococcus pneumoniae, Haemophilus influenzae, Streptococcus pyogenes, Moraxella catarrhalis, and viruses. The recommendations in this study unit are based off of the IDSA Clinical Practice Guidelines for the Management of Acute Bacterial Rhinosinusitis and the American Academy of Otolaryngology Head and Neck Surgery Clinical Practice Guidelines for Adult Sinusitis. We've already established that sinusitis can be either bacterial or viral. Appropriate treatment must consider two treatment pathways based on the suspected causative agent. Let's take a look at when symptomatic management versus antimicrobial management is required in sinusitis. Symptomatic management is always required regardless of the infecting organism. So let's start by looking at the recommended therapies for symptomatic relief. Intranasal saline irrigation has an anti-inflammatory effect and will thin out and increase the clearance of mucus. Intranasal steroids help to reduce inflammation, and analgesics like ibuprofen and acetaminophen are sufficient to relieve facial pain associated with sinusitis. Hydration is often overlooked, but it plays such a crucial role in thinning out mucus and increasing clearance. Head over to pharmacology.com study unit sinusitis to find out what commonly recommended treatments are actually not recommended and why. Let's move on to antimicrobial management. As you might guess, antibiotics are only recommended when bacterial sinusitis is suspected. Antibiotics have no effect on viruses, and exposing a patient to antibiotics when they are not needed only increases the risk of developing multi-drug resistant bacteria that are hard to treat if they become pathogenic. Viruses account for 90 to 98% of all sinusitis cases. This means that really very few cases of sinusitis will require antibiotics. Most viral cases will self-resolve in 5 to 7 days. So when are antibiotics required? Since most viral cases will start to resolve by day 3 to 5, we start to consider antibiotics if signs and symptoms are worsening after 3 to 4 days. Since most viral cases will resolve completely in 7 to 9 days, we consider antibiotic therapy if symptoms persist beyond 9 days. If symptoms begin abruptly and severely, we should consider it bacterial sinusitis. Severe symptoms include a purulent discharge, facial pain, or fever lasting more than 48 hours. In double sickening, the patient started off with a viral infection and then got a bacterial infection. There are so many antimicrobials available, so let's talk about the recommended antibiotics for treatment of bacterial sinusitis. Once we've made the diagnosis of bacterial sinusitis, the choice of antibiotics depends on the presence of risk factors for antimicrobial resistance. Anyone over the age of 65 or someone who has used antibiotics in the last month, or someone who has been hospitalized in the past 5 days, or someone who is immunocompromised has an increased risk of being infected with bacteria that has developed resistance to some antibiotics. If your patient does not have any of these risk factors, then the first line of therapy for bacterial sinusitis is the standard dose of Augmentin, which is 875 milligrams of amoxicillin with 125 milligrams of clavulanic potassium twice a day. If your patient does have any of these risk factors, then we will start with a higher dose of Augmentin, which is 2,000 milligrams of amoxicillin and 125 milligrams of clavulanic potassium twice a day. Head over to pharmacology.com to find out what antibiotics you would use if your patient has a true penicillin allergy. Augmentin is our drug of choice for sinusitis, the dose dependent on the presence of risk factors of resistance. But for how long should we treat? If we are using the standard dose of Augmentin, we treat for 5 to 7 days. If risk of resistance requires the use of high-dose Augmentin, we treat for 7 to 10 days. In most cases, we will have a diagnosis of sinusitis, treat, reassess, and find that our patient is doing great and well on their way to full recovery. But in some cases, when we reassess, we find out that our patient is not improving or even getting worse. So what do we do then? The following algorithms provide an overview. If your patient has been on the standard dose of Augmentin and we reassess around day 3 to 5 and find out they are not improving or worsening, we will change antibiotics. The guidelines recommend only changing antibiotics once. After that, we really need to look more deeply with cultures and imaging if the patient does not improve after 2 rounds of therapy. When we change antibiotics, this restarts the clock to day 1 of therapy and we will reassess again in 3 to 5 days. The algorithm for patients on high-dose Augmentin looks the same. We reassess in 3 to 5 days and change antibiotics if needed. If a patient is sick enough that they require hospitalization, ceftriaxone, Unicin, and Levaquin are options for intravenous use. For detailed notes, illustrations, and other study material, head over to the sinusitis unit at pharmacology.com. Thank you for watching.